Hi, I'm Meghan Miller, a postdoctoral fellow here at the UC Davis Mind Institute, and today you'll be hearing about some of the new work we've been doing focused on early detection of ADHD. But first, what is ADHD? Well, ADHD is characterized by developmentally inappropriate and extreme levels of inattention and/or hyperactive impulsive behavior. And it's usually diagnosed around age 7, but more severe cases of ADHD tend to be diagnosed earlier, around age 4. Now, ADHD is one of the most prevalent disorders of childhood, affecting approximately 5 to 7% of children, and it has a strong genetic influence with heritability estimates in the 0.7 to 0.8 range, so it does have a tendency to run in some families. Contrary to popular belief, most children who have ADHD don't actually outgrow it as they develop. Instead, the majority of children with ADHD go on to be adults with ADHD, and even when ADHD symptoms improve over time, long-term impairments, including lower educational and occupational attainment, higher rates of substance use problems, and even higher risk of early mortality are common in adults with a history of ADHD. So given these longer-term impairments, it seems important to try to identify ADHD as early as possible in order to initiate intervention as early as possible. And this is something we've gotten much better at in other neurodevelopmental disorders in recent years, like autism, but we really haven't made a lot of progress in this area for ADHD. And this may be in part due to the fact that the idea of early diagnosis of ADHD is a controversial one. Understandably, there are concerns about medicating young children, overdiagnosis, and differentiating typical from atypical preschooler behavior. But multiple studies have shown that careful, thorough diagnoses in preschoolers persist in the majority of cases. And a careful, thorough diagnosis can't be obtained through a 10-minute doctor's visit, but instead involves obtaining a thorough developmental history, conducting a diagnostic interview with parents, directly observing the child in multiple settings, and collecting information from multiple informants like parents, daycare providers, preschool teachers, and so on. The preschoolers who do have ADHD are at greater risk for being expelled from preschool, having poorer peer relationships than their typically developing peers, having more academic struggles later on, and are at greater risk for accidental injury as well. And although both medication and behavioral interventions are evidence-based treatments for ADHD, based on the American Academy of Pediatrics recommendations, behavioral interventions are recommended as the first-line treatment for preschool children with ADHD. Now, in contrast to early diagnosis of ADHD, our interest is in identifying early signs of ADHD in infancy. And we're not talking about diagnosing infants with ADHD, but rather looking for factors very early in life that predict the development of ADHD later on. And several infant behavioral indicators have been suggested in the prior research, including certain aspects of temperament like short attention spans, high activity levels, low levels of inhibitory control, and high levels of negative affect or negative emotion. Also, early delays in motor and language skills have been shown to predict later ADHD symptoms. But one of the challenges to this line of research is that it is developmentally typical for very young children to display these types of behaviors. So we're trying to better understand the threshold between typical and atypical behavior. So to give you a sense of what normative versus atypical levels of these types of behaviors look like in young children, I'll show you a couple of examples. Both children in the examples are 36 months or 3 years old.
Okay, ready? Watch.
This child shows normative levels of attention, activity, and impulsivity. In general, he waits for items to be given to him before using them, waits for tasks to be demonstrated, and is able to sit still in his seat while he participates in these activities. He also persists through complex tasks rather than quickly giving up when the task becomes more difficult for him.
Good job, Ryan. You are very good at saving money.
Keep that skill.
This child starts off sitting in her seat,
She's the third. Emily, okay. Or she's used to kind of be.
but she quickly stands up again. And the examiner is required to move quickly to try to maintain the child's interest. This child has difficulty maintaining her attention to the task for very long periods of time, and instead moves around the room to find other items of greater interest. The examiner and the child's mother attempt to make changes to the child's environment to try to make it easier for her to sit and complete the tasks.
want bubbles?
Here, you can see this child focusing in on and persisting through a complicated task even though it is difficult.
Oh, can you put it back on? Here, let's see you put it back on. Wow, you are very good at that.
This child shows interest in the activities and although would clearly like to touch the items being shown, is able to wait through the demonstration of the task for his turn rather than intrusively grabbing the items from the examiner's hands.
Just like this. Oh, it's stuck.
Here you can see that this child is distracted by other things in her environment and has difficulty staying seated. She also has difficulty staying still, often bouncing in her seat or standing in place.
This goes here, and this goes here. And where's this go, Emily? Out to the half. Where's that go? Where did they go? Bubbles are coming. Finish, then bubbles.
You can see this child grab items from the examiner,
Away, and then bubbles.
and she sustains interest in tasks for only brief periods of time. You'll notice that the examiner repeats task instructions multiple times and initiates reinforcement strategies in an attempt to obtain the child's attention.
Emily, you want bubbles?
So, how do we study the early emergence of ADHD? We've been using a method that has been widely used in early detection studies of other disorders like autism spectrum disorder, which you can hear more about in the Minds Behind the Mind talk from March. We focus on studying infants who are at heightened risk for developing ADHD by virtue of having a first-degree relative with the disorder. So here on the left, we have a family who has a child diagnosed with ADHD in gray. Then that family has a baby, and this baby is considered to be at higher risk for developing ADHD. Our comparison sample, as shown on the right, consists of infants who have no family history of ADHD. We also focus on infants who have a parent diagnosed with ADHD. These infants are recruited early in life and followed regularly through the infant and toddler periods, completing a variety of tasks in the lab along the way. We've been fortunate to follow a cohort of infants from 6 months of age all the way through school age, which I'll be talking about more shortly. So I'm going to present data from 2 different studies consisting of 2 different samples of children. In the first study, we'll focus on a sample of infants who are at high risk for developing autism spectrum disorder, meaning that they had an older sibling with ASD. These younger siblings, we're learning, are also at heightened risk for developing ADHD as they grow. And in this study, we followed these infants until they reached school age, between 8 to 11 years old, when we could accurately diagnose ADHD. And then we looked backward at their data from infancy to see if we could find early differences between the infants who went on to develop ADHD versus those who developed typically by the time they were school-aged children. In the second study, we've started recruiting infants at high risk for ADHD, meaning that they have a first-degree relative, either a parent or older sibling, who has ADHD. And we're following these infants from between 6 to 18 months of age to look for early signs of ADHD. We're currently seeking participants for that study, so if you, your spouse, or your child have a diagnosis of ADHD and you also have a baby 18 months of age or younger, please give us a call. You'll see our contact information at the end of the presentation. So in study 1, we're looking backwards from school-age outcomes. These children were either younger siblings of children with ASD or younger siblings of typically developing children who were all enrolled in the study before 18 months of age and who were subsequently followed over time until they were between 8 to 11 years old. At this point, we determined which of these children had ADHD and which were considered typically developing. 17 of the children met diagnostic criteria for ADHD and 30 were considered typically developing. So in this study, we were primarily interested in determining whether it's even possible to detect a signal for ADHD in infancy across several measures, including an eye tracking measure of sustained visual attention, parent concerns of behavior, and examiner reports of behavior. And the eye tracking task we used measured how long the infants spent looking at the screen while a variety of images appeared. And as you can see, the group with typically developing or TD outcomes at school age, which are shown in blue, significantly increased in the proportion of time they spent looking at the screen between 3 and 24 months of age, whereas the group who later developed ADHD, in pink, showed no growth in sustained visual attention. Also, the group who developed ADHD, by the time they were school-age children, spent a longer time looking at the screen at 3 months of age. And interestingly, we know from the infant attention literature that long looking early in infancy, before 12 months of age, is linked to a variety of poorer outcomes and is thought to reflect slower cognitive processing. So long looking times early in infancy is a bad thing. And we're very interested in following this finding up as we see more of this sample back in the lab at school age. We also asked parents about any concerns they had about their infant at the end of each assessment. And here we were specifically interested in parental concerns about behavior or temperament, which includes things like inattention, high activity level, impulsiveness, and any sort of behavioral dysregulation between 6 and 36 months of age. And what we found was that there was a significant increase in the group who later developed ADHD in terms of the percent of parents reporting behavior problem concerns. And by 36 months of age, 50% of the group who later developed ADHD had reported these concerns versus 12% of the group who developed typically by the time they were about 10 or 11 years old. And this suggests that parents are able to identify emerging symptoms of ADHD by at least 36 months of age, and perhaps even beginning by 24 months of age. Examiners also reported on inattentive, hyperactive, and impulsive behavior, and we looked at the percent of examiners who noted these behaviors for the infants who later developed ADHD versus those who did not at 12, 18, 24, and 36 months of age. And we found that the examiners were reporting these behaviors in significantly more of the infants who later developed ADHD by 18 months of age. So it appears that we can detect early differences between the children with ADHD and typically developing children across multiple measures. But many of these children had a family history of autism, and now we want to look at infants who have a family history of ADHD, but not ASD, which I'll talk about next. In our current study, we're focusing on infants with no family history of ADHD, which we consider to be low risk, and are now also recruiting infants with a first-degree relative diagnosed with ADHD, either a parent or an older sibling. If you're interested in participating, I'll provide our contact information at the end of this talk. The goal of this study is to identify early signs of ADHD among infants at risk for ADHD outside of risk for autism. I'll share with you some preliminary data from this ongoing study, spanning measures of eye tracking, of sustained visual attention, and examiner ratings of behavior. But we're also using other measurement strategies in this study, like accelerometers, which provide an objective measurement of activity, and behavioral coding of ADHD-related behaviors that occur during the assessment sessions. So in this study, we don't yet know the outcomes of these infants. So we don't know which ones are going to develop ADHD, which will develop typically, and so on. Instead, we're looking at differences between risk groups, that is, infants at risk for ADHD versus low-risk infants. At 12 months of age, these infants complete an eye-tracking task of sustained visual attention, which, like in the task described before, measures how long the infants spend looking at a screen showing relatively boring images. So here we see that the infants with a family history of ADHD spend less time looking at the screen relative to the low-risk infants, which suggests that they have greater difficulty paying attention to uninteresting tasks by 12 months of age. We also directly ask examiners to rate infants' levels of inattention, hyperactivity, and impulsivity at the end of every assessment using a modified version of the Behavior Rating Inventory for Children, which is a clinician-rated rating scale designed to identify preschoolers with ADHD. And we've modified this rating scale to be appropriate for use with infants as young as 12 months of age. And I should mention that the examiners are unaware of risk groups, so they don't know whether the infant they're testing has a family history of ADHD or not. And at 12 months of age, we're finding that the infants at risk for ADHD are being rated by examiners as significantly higher on all three subscales of the Behavior Rating Inventory for Children relative to the low-risk infants, so higher on inattention, hyperactivity, and impulsivity. So overall, these studies are suggesting that early differences in patterns of sustained visual attention, parent concerns, and examiner observations may indicate the later development of ADHD. And we're also finding that familial risk for ADHD may be apparent in measures of sustained visual attention by 12 months of age, and that examiners unaware of family history may be able to identify familial ADHD risk by 12 months of age via very simple and fast behavior ratings. So this work suggests the potential for earlier detection of attention and behavior regulation problems than has previously been possible. We'd like to sincerely thank all of the families who have participated in our research over the years. We couldn't do this work without you, as well as all of the members of the Infant Sibling Study team here at the Mind Institute. If you're interested in participating in our ongoing study, we're currently recruiting infants ages 6 to 18 months who have an older sibling or a parent diagnosed with ADHD. Participation in the study involves close monitoring of your baby's development with feedback from expert clinicians, as well as compensation for your time and effort. Please contact Alicia Hill at the number and email address on your screen if you're interested.
The UC Davis Mind Institute was created in 1998 with a promise to find cures for neurodevelopmental disorders. Every day, our physicians and researchers come closer to fulfilling that promise. Their groundbreaking research on autism, Fragile X syndrome, chromosome 22q11.2 deletion syndrome, ADHD, and other brain disorders are helping children achieve their fullest potential. Please visit our website to find out more about current studies, upcoming events, and how you can help make a difference.